Here we will be talking about the aminoglycoside group of antibiotics. What is their place in current day practice? They are mainly active against gram-negative organisms, and our interest in them is only because can they be used in multi-drug resistant gram-negative organisms. They have no activity against anaerobes and also should not be used in anaerobic conditions because their entry into the bacteria is dependent on the presence of oxygen. Currently, we find use of aminoglycosides as a combination therapy in brucellosis, in multi-drug resistant tuberculosis, but here also it is falling out of favor, Pseudomonas, nocardia, and listeriosis. Majority of the time we use it IV, but there are other forms in which it is available, like tobramycin for nebulization, gentamicin for both intraperitoneal and intraventricular injection, and oral neomycin, which does not get absorbed. All aminoglycosides work by binding to the 16S subunit of 30S ribosomes, and this inhibits protein synthesis. It is generally considered a cidal agent. What are the concerns with aminoglycosides? Neurotoxicity. They almost can produce a neuromuscular junction blockade kind picture and should be avoided in myasthenia. Ototoxic, both vestibular and cochlear. Hearing loss with aminoglycosides may be irreversible. The one place where they really have been used for long is in multi-drug resistant tuberculosis, and there we find it's really toxic. It's nephrotoxic, and this nephrotoxicity is predisposed by dehydration, pregnancy, and liver disease, use of diuretics, and the presence of other nephrotoxic drugs. It was a popular antibiotic till the 1980s, but it got replaced by quinolones, cephalosporins, and carbapenem. So you had an oral alternative now. The place where aminoglycosides found greatest use was with urinary tract infection, and quinolones were great then. So aminoglycosides went out of favor, and the renewed interest is actually due to the multi-drug resistant bugs, and we have newer agents. Plazomicin is the newest one, approved 2018, and there are two more agents. One is arbacacin and one is isepamycin, which has been there for long. They have the convenience of once daily dosing, and that is generally what is advised for decreasing the side effects. Let's look at the spectrum where we are interested in now. The enterobacteriales, the enterobacteriaceae like E. coli, Klebsiella, they can show sensitivity to aminoglycosides. It is also active against Staphylococcus aureus, and some of the agents are promoted to be used for as an MRSA agent. And they also have activity against Acinetobacter. There is a synergism supposedly with beta lactams, so they work on the inner machinery, and the beta lactams work on the outer cell wall. And one of the places where this has been exploited is in the treatment of infective endocarditis. What has happened over the years is the bugs which for the aminoglycosides indented to, especially the gram-negative bugs, they became resistant. And the causes of resistance were enzymatic, the most group of enzymes called aminoglycoside modifying enzymes, and majority of the ESBL producing gram-negative strains also elaborate AMAs. So then generally we consider whenever we have an ESBL that probably this will also be resistant to an aminoglycoside. Then target site modification and the employment of efflux pumps. It's a water-soluble antibiotic supposed to enter the cell through porine channels, so defects there can also cause inaction, and then efflux pumps employed may actually throw the antibiotic out. The aminoglycoside modifying enzymes are something which do not destroy plazomicin. Otherwise, like amikacin and tobramycin and gentamicin, all of them get inhibited by aminoglycoside modifying enzymes. There are also issues with the pharmacokinetics of aminoglycosides, and what should be considered as therapeutic level. Should it be the time in the MIC range, or should it be the Cmax to MIC ratio, or should it be the AUC MIC ratio? Majority of the time we thought the Cmax was most important, something we call as concentration dependent antibiotic, and that is why that one single shot high dose which achieves higher peak levels may be having therapeutic benefits. Well, that argument is not very clear. And in patients who are critically ill, not only is there a problem of renal failure and reduced antibiotic clearance, but also of augmented renal clearance, ARC. And this can significantly decrease the levels which the aminoglycosides achieve. All these antibiotics are renally cleared and they are equally renally toxic. So, this has to be kept in mind, especially because the therapeutic window is very narrow. You exceed the dose, you have toxicity, you fall below, you have inefficacy. And it's a dialyzable drug. And the word is not out, should we use it pre-dialysis or post-dialysis, how you should dose it in terms of timing in patient who is on dialysis. And should we do therapeutic drug level monitoring? Ideally, yes. But how many of us do that? Very few. So, if we have therapeutic drug level monitoring and we assume that we are in the right range, maybe we achieve better efficacy with less toxicity. So, we have the new aminoglycoside plazomicin to talk about, which has kind of renewed our interest in the aminoglycosides. And now we are using it for the drug resistant bugs like carbapenem resistant organisms. Plazomicin is approved since 2018 by FDA for treatment of complicated urinary tract infection, and here it was tried against quinolone, levofloxacin. That was a comparator. It was also tried for pneumonia, but the trial did not get completed because of lack of enrollment. But off-label, maybe we can use it for ventilator-associated pneumonia when we are considering a drug-resistant bug. What is the advantage of plazomicin? As we discussed, it is stable against the aminoglycoside modifying enzymes. But if the bacteria elaborates 16S methyltransferase, it becomes unstable. So all aminoglycosides become unstable when the bacteria elaborates this. And one of the problems is that organisms which have the NDM carbapenemase, they also frequently elaborate the aminoglycoside modifying enzymes and 16S methyltransferase. So once we identify a bug to be an NDM, the likelihood of it elaborating 16S methyltransferase is more than 50%. Well, in that case, maybe aminoglycoside should not be used. With this in our mind, let's look at where we can apply it. Carbapenem resistant enterobacterials, yes, that's one place. But then we have the newer BLIs available for them, which are less toxic and which are kind of the first approved drugs for this indication by IDSA, use first up. Acinetobacter, very interesting. And here it could be a better substitute to colistin. So we are just looking at the possibility wherever we are using colistin, can we be using a newer aminoglycoside? So one place for it could be as a substitute to colistin. And this colistin is something that we use for both enterobacterials and Acinetobacter. So new aminoglycoside can also be used. MRSA, yeah, the Japanese molecules, they claim that it's a very good agent against MRSA. And infective endocarditis is a combination therapy we still continue to use. So there might be an evolving space for aminoglycosides, and the idea was here to just touch upon the very basics of it, keeping in mind that it could be both pharmacokinetics and pharmacodynamics which determines the outcomes.